Very excited to have the peri-implantitis with me again this year. I'm Matt with Maxius Dental. I think that's the first time I've said that. If you haven't heard, Snoasis was acquired by Maxius on September 27th, so very exciting for us. But with that, I want to go ahead and kick it off, and I'll turn it over to Dr. Curry Leavitt to get us started.
Perfect. Let's see, are we good on mic? Maybe. Hello. One, I appreciate you all being here. I know that it's kind of a trek to get over here to the corporate forums and to hang out with us. We're super excited about the program. I know there's going to be a lot of information, a lot of nice cases, but more of an understanding of why we utilize this type of membrane and this type of biologics, to add to our cases. And so we have a great group with us, Dr. Bradley Ross from Miami, Dr. John Kim from Rocky Mount, and Israel Puterman from Washington, D.C. We get together quite often, and do a lot of these presentations. And so with that, this is kind of our little intro that we like to throw out there. We try to make this more exciting.
Cool.
And
wow.
Yeah, this is us. So the four of us, like I said, you're going to get a great understanding and a better, appreciation of kind of what we do and why we do it. With a small group like this, it can be interactive now. So if you have questions or whatnot, we're going to try to hold those off until the end. But if something is like absolutely pressing you and you want to, bring it up to the group, absolutely do so. And in fact, we could probably go around the room and introduce ourselves if we want. So, but we're not going to do that. Instagram is how we all met. And so, back in pre-COVID days, we got on Instagram, we started following each other. That's how I met Israel and John and Brad. We must have, swiped right together or something, and we became instant matches, but we've all become best friends over the years. So if you want to get on, follow us on Instagram. It's a beautiful platform in terms of getting on with each other and, compiling ideas. And if you have questions, it's like one of those things. It's like early on, I was like, man, I have a question on this soft tissue graft that Vanessa did in Brazil, and I hit her up in Brazil, and like within an hour, she gets back to me and goes, oh yeah, this is my flap design, and this is what I did. And I was like blown away about how much interaction you can get through that type of a platform. So with that, we've all become super good friends. I grew up in Las Vegas, and so in Las Vegas, I competitively swimmed, and it's one of those things I still do to this day, to where I can put my phone down and get underneath the water, and it's like this serene time, where I can do that daily, where it's just like just get away from everything. When you think of swimming, the one thing that pops into my mind is probably the greatest athlete that we've seen in U.S. history, or U.S. Olympian history. And if you know who that is, the great Michael Phelps, the most, gold medals ever won by a U.S. athlete. And you can see here I don't know how he's holding that up, but one of the things was continuing education. And I always like to, start courses out like this on kind of a broader perspective of why in the world are we here, right? Why are you here to sit in a CE course, to hopefully go back on Monday knowing something different, right? Or doing something that maybe is going to set you apart, maybe from your colleague, or you might have a inspiration to do something more business, specific, or the way you talk to your team, or the way that you present treatment. Obviously, today we're going to talk about modalities in order to improve your cases, with a plethora of applications. And so, what are you going to do to make yourself different? So think about that as we start this conference off. You're going to have 2 or 3 days here to really bring something home with you, right? And so hopefully you can take something from us, but think about that as you go into each room. And this is one of the things that Michael Phelps does. You can take a picture of this. We're not going to go into it, but these are things that will set yourself apart, okay? Whether it be on a personal level, whether it be on a business level, whether it be as a periodontist or surgeon. It could be a father, could be a spouse or a colleague. These are the things that are going to set yourself apart, and it really comes down to hard work. And so with that, I think that that's really the institute of where we want to be. And so, but let's talk about what you're here for today. So this is BioXclude. BioXclude is a barrier and a carrier in one product. And so what do I mean by that? Is that it does a lot of things for us. It's just not an exclusive or an exclusion barrier, but it adds something to this too. And so it is an immunoprivileged, antibacterial, anti-inflammatory, and it does offer accelerated healing, especially in an exposed environment. And so, with that, the amnion-chorion bilayer, so it's 2 layers, okay? And some of the most, beneficial parts of this type of barrier is that it contains the basement membrane still. And so the basement membrane, and if we look at, biology, what does that basement membrane do is that it's self-promoted or self-accepted. So when we bring a human product in to a human environment, self-recognize self. And so it's like with that basement membrane characteristics, it's also very versatile in terms of being very flimsy and very flexible, but also offers a lot of strength with this too. And so within the chorion membrane, they have a basement membrane too. And so the way that this is processed is very specific. And with that too, like I said, we talk about being immunoprivileged, but we also talk about anti-inflammatory characteristics. And so if you think of immunoprivilege, when you put something in the body, if we can enhance the immune response to this, it's going to be super beneficial for wound healing. So normally, when the normal barriers that we put into our patients, especially non-resorbable membranes, what are we inducing? A huge inflammatory response, right? And in fact, it's an inflammatory response accelerated. And so you end up with this prolonged inflammatory phase, and then you don't get wound healing the way it should. Now, if we can take that and then decrease it and have this inflammatory cascade where we get the proliferation and remodeling and maturation way quicker, well, that adds a lot of benefit to turning things over better, right? Turning things over better faster, turning things better over more frequently and more consistent. And so there are a lot of biological material or growth factors that are involved in all of these membranes as well. And so we get better cell proliferation and tissue regeneration because we have all of this, like over 200 growth factors. And we could probably go around the room and we can ask like, hey, do you guys know what ELBP1 does? And you all would probably know. I don't know any of this shit at all, but that's okay. They're in there, right? And they do a lot of things for us. And so what does the membrane, situation look like in our practices today? And so that's what we have, right? So we have PTFE membranes, titanium reinforced, non-resorbable. They're used for a number of applications. We can use titanium mesh, right? Now we have prefabricated titanium mesh to where we can take digital scans and build up height of bone and width of bone a lot easier with these non-resorbable membranes. This was kind of like the gold standard, right? As we did a lot of things with GBRs and GTR procedures or even repair procedures, is we have these collagen cross-link membranes or sugar-link membranes, and there's a lot of membranes out there on the market, porcine and bovine and human products, allografts. And now we've introduced ourselves to the amnion-chorion game to where hopefully, like I said, you can come home with a lot of appreciation for what's available with that. And so with that, we have reinvented the membrane rules, okay? So one of the things that's nice about this is we can keep a lot of our wounds super non-invasive, where we don't have to elevate all these major flaps, especially in like immediacy of where we're extracting teeth, placing implants, and placing a membrane in those situations where we can leave the membrane exposed. We're not elevating these large flaps when we do so. We don't need to trim these membranes. And so what you're gonna see too is that we can then, tuck membranes into places or even put it over sinus repairs to where we don't even have to trim these. I mean, it's just literally a fold on itself. It's like cellophane, okay? No need to fixate it. It has this adhesive kind of a characteristic where it just folds on things and adapts to things. And like I said, with adhesion, we can now use it as repair, okay? And so with that, as Brad and I were talking about this presentation, we're gonna give that today together, is that I was like, man, repair and regeneration. And he looks at me in the eye, and we're in Las Vegas, and we just got done golfing, and this is a couple weeks ago, and he goes, man, do you remember that commercial where the dude takes this adhesive tape and goes, and slaps it on this thing and seals it up? And I was like, how applicable is that? That's perfect. This is exactly what this membrane does. It kind of adheres to things, and it's just really, really nice. But we're going to talk a lot about repair today, especially the first 40 minutes or so. And so with that, within sinus repair, this is where we utilize this membrane quite a bit. So we're going to hand it over to Brad. He's going to talk about that.
Right, so as Curry was saying, we were at dinner last week and we were kind of talking about how to approach today versus just kind of saying, here's a product, here's how we use it. And as we were going through our cases, we were like, man, these are all like fixing problems kind of cases, things that we're trying to, like you said, repair. and then we were, like you said, we looked at each other like, that's what we're gonna do. We're gonna talk about why this particular membrane is so essential with this specific topic, more so than I believe any other product on the market. So when we're talking specifically about sinus repair, there's a couple, maybe 3 different modalities that we're gonna go through. One is a pre-existing perforation, something that I, unfortunately, for some reason, have been seeing a lot in my practice in Miami, where we have patients that are coming in with molars, maxillary molars or premolars, with some type of abscess, whether it's associated with a fracture or a failed root canal or whatever it may be, that has perforated the cortical plate inferior to the maxillary sinuses, and now we have this hole, right? And you guys have all seen this, I'm sure. Now, in these kind of cases, the question that we first have to ask ourselves is, hey, what do we do? Is this something that we let it close up on its own, let that Schneiderian membrane reform before we go back and try to throw bone graft with the fear that we're going to throw something in there and it's going to get stuck in the ostium and we're going to have a big sinus problem? Well, in my practice, I have been using this specific material to repair these, and I'm able to always have forward progress. So you can see here where that infection has gone through the sinus floor. You can see the radiopacity in the base of the sinus. And so here's the case clinically. And you can kind of see here, but there's a pretty good sized perforation. And so what I decided to do is, depending on how big that perforation is, one approach is I can use instruments to try to elevate what I can see of the sinus membrane around the perforation. If it's a bigger perforation, there's another way of placing this in. So one way I can pack this membrane inside against the tear, or another way is I can actually just place it inside the sinus, inside the socket like this where it lines, and because of its adhesiveness and its characteristics of handling, it kind of just sticks. So it sticks to the bony walls of the socket, and now I have a little kind of like blanket that's blocking that perforation. What I then do is I put usually some type of xenograft collagen, it's a little bit softer, at that base part, and then I can fill the rest of the socket with my particulate. And so you can see here, this is how it starts, and this is it at 6 months. So you can see kind of that xenograft bone at the base, but you can also see how the bone has, that cortical bone has reformed. The sinus itself is now radiolucent instead of radiopaque. And you can see how this is used to heal that. The next 2 types of sinus repair involve perforations during either indirect or direct sinuses, lateral wall, or using, whether it's osteotomes or versa drills or whatever it is you use. But that's something that happens no matter how good we are, it happens, right? And perforations are the main complication during any kind of sinus augmentation. And these happen in literature, it shows anywhere from 10 to 58, kind of the high 50%. But there's a lot of research on this, but we all know that it happens no matter how good or bad you are, it happens, and it could be due to anatomical variations, it could be due to thinness of the membrane or something that we do wrong. But we have to know how to fix it. So Curry will start us off with a direct sinus.
So yeah, one of the really advancements that we've seen, especially without utilizing osteotomes and these tapping situations, is utilizing burrs or versa burrs to elevate the sinus during an indirect sinus elevation. And so we do these quite often. But as you can see, you can get complications with any type of micro perforation, or in this case, even a 1 to 2 millimeter perforation. What was our choices at that point? Was either one to leave the procedure, right? Just try to let it heal in on its own. You might even have an oral antral communication because of so. Or do we proceed with our treatment? And so utilizing the BioXclude membrane, this is a 12 by 12 membrane, we can look at our perforation, we can place our membrane within this. If we place it in there dry, it kind of has this adherence to the Schneiderian membrane. And now we can go ahead and then elevate our sinus like we did before. And so you can see a fairly large pneumatized sinus. Even in a pneumatized sinus like this, we can be a little bit more aggressive in terms of putting implants in immediately. And with the before and after, as even with a perforation, to where now we can get nice elevation, even in an indirect manner, to where even if this patient wants now a second molar, look at, we've got bone even in that location. And so, beautiful case, where we can go through, immediately place our implant, nice bone, and not having to leave our procedure. And this is even at a 4-year follow-up.
So as you saw there, he placed the membrane, pushed it down into the base of that osteotomy site to cover that perforation. I'll show you a different kind of way of doing it, but this is the same kind of scenario, placing an implant in a maxillary molar. See the site's prepared, there's a small perforation. So what I do is I use some instruments to try to gently elevate around that perforation when I can. And then here you'll see kind of an illustration of how that's done. So I use 1 or 2 different instruments, but I'll try to use this instrument to kind of gently just push up the membrane. And then once I've kind of had it a little bit released, I can come and I can put in, you can see how it's done here, but I can go and then put a piece of BioXclude in. When handling BioXclude, just a little side note, having your instruments a little wet helps. Otherwise it can stick to the material and then it gets a little bit more challenging to maneuver around. But I like to place in this particular, I place the actual membrane itself dry. The blood in the area will kind of cause it to kind of stay in the spot. Then I use a xenograft collagen here because I like to use something that's just a little bit gentler near the sinus. And then I can press this up with bone packers and get it to the base of that where that perforation is, and then my membrane and everything kind of work as one. Then I can go ahead and this is where we start before the surgery. This is the day of placement, and then this is a 2.5-year follow-up. And you can see how everything kind of healed in really nicely, the membrane, the cortical bone kind of reformed, and we've got nice fill.
One of the things with the all-on-X treatment is, and we do a lot of full arch in Las Vegas, to where I like to stage cases too, to where not only do we immediately place implants and load cases and send people home with teeth, but I like to build a foundation in the sinuses to where we can add a 5th or a 6th implant posteriorly, especially if we're looking at a greater AP spread and whatnot. But even during those lateral window situations, this is Dean. Dean's a truck driver in Las Vegas and just a super sweetheart of a guy. And so, but his AP spread was very limited. So we knew that we could place 4 implants in the anterior zone. We can give him some type of a first premolar occlusion. He was okay with that, but eventually, especially the dentition that he had on the mandible, we wanted implants in like the 3 and 14 position. So we then staged that. At the same time we do our all-on-X, we're gonna do a sinus graft as well, and then come back in and place those implants later. And so with this, fairly large pneumatized sinuses, okay, and so with that, you can have perforations, right? And so even in a smoker, a previous smoker like Dean, a little bit thicker of a membrane, sometimes within, septum of the sinus and things like that can be challenging. And even a large window here, we identify our perforation. Now, what is our choices, right? Michael Picos, oral surgeon in Florida, he talks about tacking all these membranes and collagen membranes and reinventing basically your anterior and posterior and superior walls, and it's a very technique-driven repair. Or we can take our BioXclude, like I said, it's almost like this cellophane material, and we can put that over the top of this perforation. We bring it in dry, and it just basically envelopes over the top of where our perforation is. Now, in these cases, with a larger perforation, like say 8 to 10 millimeters, I like to do a bilayer technique where we do two membranes. So this is a little bit thicker. We can go through, we can place 2 membranes here. You can appreciate where we've already done our full arch treatment here in the anterior. And now we can then go through and just say, okay, let's see how well that this really sticks together. And so now elevating that membrane up, having the patient breathe through and out, we don't have that oral antral communication like we did. And so nice adhesiveness, looking really good. And now we can proceed with treatment, even in a case like this. And so we go through, we do fairly large amounts of bone here in the sinuses bilaterally. We can come back in after 6 months. We can then place our implants. We can then further enhance, again, occlusion and aesthetics and a better overall treatment plan when he's also getting implants on this lower left side. And so when it's all said and done, this is where Dean starts. and then where he goes home today. It's a beautiful treatment where we can go through and literally start from scratch and provide somebody with nice dentition like this. And so even in a lateral perforated site, you can do that. Nerve repair. This is another one that's a unique opportunity where now we can use BioXclude, especially because we have this enhanced biologics, we have all of these growth factors with this membrane, is that we might see situations like this in our practices. And so this patient was treated by one of my referral base, a general dentist, had a tooth extracted. That extraction and the periapical pathology went into the inferior alveolar nerve canal. As they curetted that out and then also placed bone, what happened? Well, that bone now compresses into the nerve. The patient goes home with paresthesia, and after 6 weeks, the patient then gets referred over to me and says, hey, is there anything you can do with this? And so this is the day of that we see this, okay? And so what is the treatment of choice is where we go through now and we want to curette or remove all of that bone grafting material and try to identify where the damage has occurred. And so with this, you can visualize here is where we got the inferior alveolar nerve here, and you can see that the sheath of the nerve is damaged, but not severed, which is great. And now you can appreciate where we use some microsurgical instruments to elevate underneath the nerve, and then we are going to take our BioXclude membrane and wrap it around this portion of the damage. So literally, we go through and almost pigs in a blanket. Is basically what we're doing. We're just taking this nerve, wrapping it up, nice and cozy here, and then we are going to then just place a collagen plug over this, get primary closure over our site so we don't get any type of reinfection or inadequate healing. And then after 6 to 9 months, we've been following up with this patient at 18-month follow-up, complete resolution of any type of dysesthesia or paresthesia. So a very unique way of utilizing this membrane. Now, how many cases are you going to see this in your career? 1 or 2, but as long as you have the armamentarium to treat it, and it might even be something you've induced yourself. So with that, you do have a light at the end of the tunnel with even utilizing a membrane in this manner. So oh, here we go. Never mind. Let me keep going.
Yeah.
I like to hear myself talk. So peri-implantitis, this is a huge topic of conversation. I mean, if you look at what's on the docket at this conference, peri-implantitis is absolutely, at the forefront. And so these are the type of defects that we see, don't we? We see these moat-like defects around these implants. Well, one of the things when I was in Italy, this is back in 2018, and I was touring the Vatican, and this is the Bramante staircase in the Vatican, and they tell you you're not supposed to get out your phone, you're not supposed to video anything.
Order of everything.
Well, as I came up to the staircase, the first thing I thought in my head was like, man, this reminds me of something. This reminds me of bacteria going down an implant.
Thanks, man.
Like, a thread goes down, right? So I'm comparing all these Italians to bugs and bacteria, but I couldn't help myself but getting my phone out and going, oh man, this is going to be perfect to explain how peri-implantitis, I believe, occurs. And so we have an induction of bacteria around the threads. They kind of work their way around, and we get these circumferential or moat-like defects that are around our teeth. And so if you look at my practice, and so treating ailing implants has absolutely been at the forefront. And so from 2021 to present, these are patients, not sites, right? 348 patients in the last couple of years. If you divide that by how many days worked, I see these patients almost daily, okay? And so what is that to be said about Las Vegas? I don't know. Implants may be placed wrong or by the wrong people, or maybe we're just like the Italians and just like bacteria, I don't know. But there are a lot of circumstances like this, and this is one that came into Brad's office. And so when do we try to treat these? In terms of ailing implants, do we try to save them? Do we not try to save them? There's like this plethora or this diagram in my head going, man, if there's more than 50% bone loss, maybe we take that out. Is the implant mine, right? If the implant's mine, then I'm more apt to probably try to save these. And is this your implant, Brad?
This is actually, yes, this is an implant that was placed 8 years previous. Patient I hadn't seen in about 8 years. But like Curry said, my practice has every year grows about 5% on treating peri-implantitis cases. It's every year I see more and more of them, and some are mine and some are from other places, and it's just part of what we do. We're becoming, like part of our specialty is becoming fixers, right? So again, like Curry said, we have to evaluate when we can fix something, what the predictability is, but also sometimes patients want to try. Patients want to do, hey, I don't want to lose it, I want to try, even if it's a failing implant. We want to try to save it. So what can we use? What are the best products? What are the best things we can use to help give us the best chance of fixing things like this? For me, in these kind of cases, I'm always removing the crowns, and I'm always putting cover screws on, and I'm trying to get primary closure to give these the best chances. So how I treat these, this particular case, there's a moat defect kind of all the way around it, and then also on the facial, there's about 3 millimeters of vertical bone loss in the facial. So my protocol is I first go around, I curette any granulation tissue, any etiology from around the area. I use a rotary titanium brush. I'll go around the implant. I find that this really helps clean, and then I can go through and I place some kind of detoxifier, whether it's EDTA or Pref Gel or something around it that can help me just kind of clean, right? So that's my first phase of this treatment. The next thing I do is I'll go and I'll put some bone graft in, and the bone graft usually involves some autogenous scrapings. I'll throw some growth factors on there, whether it's whatever products I can use, whether it's PRF or, and then I put this is where one of the other indications that I always go to this membrane. I think that what I'm adding with it, with all the growth factors and things, this is going to give me the best chance and has given me the best overall results. So I'll go ahead and place that over the implant, and I get it nice and covered here. So you can see this whole area is covered. And so this patient comes back and sees me at about 3 months. Here's the 3-month x-ray. Then they came back, disappeared for a little bit, came back at 8 months. We see really nice bone fill in here, but how is this going to translate to clinical, what it really looks like when I go in? So here's where we started, and this is where this case finished. Yeah. So again, I think picking the right cases, but also using the right armamentarium and having the right biologics, I think really helped me in this case. And I had bone growth on the facial there where I regrew all that vertical bone growth, and obviously I got super lucky where we grew some over the crest.
So like I mentioned before, is we do a fair amount of full arch restorations and full arch surgery. And so there can be complications where we need some type of repair or initiation of repair and true regeneration during these cases, even in a digitally planned, facially planned environment, is that we can take cases like this where this patient's very caries prone, has had multiple restorations throughout their years, and we're breaking teeth off at the gingiva and having the integrity of the teeth are gone. And so this is a full mouth rehab on implants. And so I do a lot of guided surgery. And so with utilizing guided digital technology is that we can use stackable guides now to utilize these guides as a bone reduction guide and an implant guide, and with our implants we can place these in the most perfect position, biologically replacing teeth where they should be, right? It's just not putting implants in just some location and then trying to retrofit a denture to it. We are digitally planning these to the point where we have the teeth are manufactured first or digitally derived first, and then we can figure out where these implants are going. And so we can put these implants in guided, utilizing very amazing surgical protocol with guided surgery kits and things like that that are less invasive and less involved in these spoons and all these other things. We can use these carriers, and now we don't have osteotomy derived guided surgery, but length derived surgery. And so very, very wonderful way to do it. We can carry our implants into these guides and, like I said, adjust torque value and understand where we're at. And this is an all-on-X on 4 implants here. And even with the amount of periapical pathology, placing implants in the direct places, with some of these extractions, especially in individuals that are caries prone, where nature hasn't done a lot of the work for us in order to get these teeth out, sometimes those teeth are a little difficult to get out. Right? And so canines and premolars, especially first premolars, you take these out, usually what happens with that? The facial plate comes with it, okay? And so we then load our prosthesis here, and we're gonna pick this up on our implants, But this is what is then left after we have our prosthesis, being kind of adjusted and refined. I'm getting ready to suture this up, and this is what we notice is that we have a first premolar here that came out with the facial plate. And so now what do? Right? We obviously have to graft this, or we have to move our implant. And so, but if you're gonna have a better appreciation of where this implant is, because it was derived digitally and it was guided, it is right up against the anterior border of that Schneiderian membrane and the sinus. And so there's really no other place to put this implant. So we go through, we utilize PRF sticky bone. We're gonna then build this by bulk and really, make this robust and overfilled here on our defect. And now we can then take our BioXclude membrane and drape it over this, because a lot of the integrity of our bone here is done by that PRF situation. So PRF sticky bone has absolutely revolutionized the way I practice. We can place our membrane over here, we get exclusion, but we also get nice soft tissue healing and enhanced healing overall because of the biologics that are found in this membrane. We get nice primary closure. We're gonna then take a little bit of that tissue away from the palate, always maintaining as much keratinized tissue on the facial, because if we eliminate mucositis, we eliminate peri-implantitis, which then we end up having no teeth on implants, right? And so having nice, robust, good gum tissue here around all of our implants, we can then load our patient here and the patient goes home. At 6 months now, we can come back and now look at the amount of bone here we've got on the facial. And so where that big dehiscence was, now we have tumor-like bone, right? 7, 8, 10 millimeters of width around this bone. We will never have a problem, hopefully long term. And so patient then is happy. We go through some type of final restoration and utilizing BioXclude that way, in a regenerative way, utilizing GBR. And you're gonna hear more GBR technique, I believe, from Israel, right?
Yes.
Yes.
Just to comment on his case there, one of the beautiful things about the handling is when you're using this for GBR, because it's kind of sticky on the bone, it almost acts to stabilize and just hold the bone where it is. So it's got, again, one of the great characteristics is that adhesiveness, and that also comes into play with what we're about to talk about with guided tissue regeneration. So at the base of it, we're all periodontists, right? We're all still trying to save teeth, and we have patients that come in and have bone loss, and we see periodontal disease. I happen to find that tissue regeneration, getting good results with GTR is not very easy. And I've tried, again, a bunch of different materials, bones, stuff like that. And the results I've been getting recently with BioXclude have been really, really exceptional. And we still really need to find ways to save teeth and not just jump to implants all the time. So here was a case, it's tooth number 31. I had deep probings on the distal, on the facial as well, and you could see a pretty big defect here. It goes into the furcation on the buccal, wraps all the way around the distal. So again, went in, cleaned this out, put some pref gel, some EDTA in here to clean off the root. Went back in and grafted, and I placed the BioXclude membrane over. And again, for these kind of cases, it just sits on really nice, super easy to place, and wrapped around the buccal here to get over that furcation as well. Then you can see here, this is how it ended up, and this is about a year later. So we went from this to this. Another case here, this was a patient who came in to see me that had, in all 4 quadrants, this very similar kind of defects. So I'll show you here the upper right and upper left. Pretty significant defects, loss of that buccal facial plate, loss of bone on the roots as well, on the facial. These were cleaned out, same kind of process. You can see the BioXclude membrane on the upper left there. Very easy to kind of drape in. You place it dry, push it through, and it just kind of adheres over everything. So this is the upper right, before and afterwards. This is about 8 months later. And here's the upper left, very similar kind of results. And you could see just from the x-ray, you could see that there's no buccal lingual plate there, palatal plate, and what we were able to kind of achieve, and by this tooth, hopefully a very, very long time. So it's just showing kind of the diversity that this membrane offers and what the different things that we can use it for, whether it's grabbing onto something in the sinus or trying to fix an implant or trying to, save a nerve. The diversity, the things we can do with this at a minimum as an addition to our armamentarium is really, really fantastic and has really helped me personally achieve better results when I do use it.
Like it was funny, I mean, when I was, I think back of kind of my progression as a periodontist since I left residency almost 20 years ago, was how inconsistent I was in GTR procedures. How frustrating that was to where I'm like, man, I'm looking at this defect, even like 4-wall defects or 3-wall defects. I'm cleaning them out completely thoroughly. I'm throwing, citric acid at these things and EDTA and refining the roots and perforating the bone and putting grafting material in there and membranes and getting closure over this. And I'm going, why in the world am I getting so inconsistent results? It was like driving me crazy. So I'm like, I'm just going to take everything out. Like this is like back, 10 years ago, I'm like, I'm just going to take them all out and replace them with implants, which is completely asinine. And now since this membrane has become like a major part of my armamentarium to where I can then don't have to trim a membrane, it adheres to the teeth on each side. Because of the capabilities of having that membrane even left exposed in a coal space or an interdental space, that you still get adequate healing, which is super fantastic. And so utilizing that membrane in the GTR procedures, and I know you've seen, sinus repairs, which we do see often. Even in my practice, we see it. In nerve repair, you're going to see that very infrequently. I know that's a fun case to look at and appreciate. But in GTR procedures, we do GTR procedures every single day. We're saving teeth every single day. We're seeing peri-implantitis almost every single day. And so between those two modalities, I think that there's a huge benefit in terms of utilizing this membrane. And so we talk about the benefits of BioXclude. You get this adhesive, characteristic. We definitely have more control to where, like I said, it's not this thick membrane or something that I have to cut and form within these defects. You get enhanced healing due to growth factors, which we see here. Antibacterial, which is fantastic. We can keep bacteria away. We get better at healing, anti-inflammatory characteristics. And if you look overall, you get really true regeneration utilizing this membrane, better than anything I think I've ever seen, especially in GTR and peri-implantitis cases. And so with that, I hope that you have a better idea or at least a better appreciation of kind of where we've taken this. We've used it in some off-label characteristics and situations. But overall, and then with Dr. Kim and Dr. Puterman, who's going to then even take this to the next level, I think you'll even have a better appreciation of kind of where you have 4 different surgeons or 4 different clinicians using it in so many different ways. But what's the best thing is that the end result is something that is enhanced, and who benefits from that every single time is our patients, and that's the one thing that we're always trying to do is when I come to meetings like this, and I'm like, what am I going to take back with me to better my patients? And that's I just want the best for them. I want the best long term for them. A lot of this, treatment, it can be expensive. And so we want to make sure that we, like I said, offer the greatest results with the best materials that we have at our disposal.